Okay, so welcome everyone. So today we'll be starting off with a new series on psychopharmacology of lithium. So in front of us, we have a question from INICET November 2023, where a pregnant woman who was on lithium prophylaxis for a bipolar disease came for follow-up in third trimester and reports adequate symptomatic relief. So what should be done next? Okay, so A. Stop lithium. B. Decrease the dose. C. Increase the dose. And D is changing to valproate. Okay. So here we have a situation where a pregnant woman who is sh- in her third trimester is coming to us, and we have the option of either stopping the lithium because she is very well controlled on the bipolar disorder, or can decrease the dose. Increasing the dose doesn't seem to be like necessary in this case. Apparently, like, let us see into the explanation. A change to valproate. Okay, maybe. So the answer of this question is decreasing the dose of the person. Okay, so we will decrease the dose. So the question actually states about the woman being in the third trimester of pregnancy, and she might be approaching her labor at this point in few months or few days. So what actually happens? So there is a fluid shifting that happens. As the fluid shift occurs during second semester, there's a whole lot of fluids. Okay, so during delivery you can see there is a whole lot of concentration is happening. The fluid has decreased because of the loss of amniotic fluid and the baby coming out, and after delivery the fluids are almost not there, which is like back to the normal. Okay, so here lies the danger of toxicity. Okay, so this was the logic behind decreasing the dose of lithium. So what exactly is happening? It's something like this. So with the increasing volume of fluid during the pregnancy, we need to increase the lithium dosage just to keep the therapeutic levels. But as soon as delivery occurs, the fluid volume shrinks and there is a very high chance of toxicity. So, as to prevent this toxicity to happen, we have to reduce the dose of lithium. Okay, you can see over here. See, this is what Kaplan Sadok also talks about, that there is a massive intracompartmental shift of electrolytes before, during, and after delivery, which can make a sudden lithium toxicity possible. Okay, and this is what is happening during the delivery. So before the delivery, what was happening is there was increasing glomerular filtration. So more and more amount of lithium was being thrown. See, this is what is written over here. So lithium clearance rises throughout the pregnancy as GFR also increases. So a fixed dose gradually gives a lower blood level, and many patients need their doses increased across the first two trimesters just to stay in the therapeutic line. See, so this is what is happening during this phase. It's like a flight of blood volume, along with also there has to be a flight of dosage in order to maintain the therapeutic levels. Okay, so this sudden volume loss leads to sudden increase in concentration of lithium and precipitate toxicity. Okay, so this is what it is, and that's the logic behind decreasing the dose of lithium. Let's look at the other options. So stopping lithium outright is reserved for the day or two immediately before the delivery. So had it been the question just before delivery, okay, so just before delivery, then this might have been the right option, option A. Okay, okay, let's just look at the other questions, other options. C is ignoring the delivery toxicity risk. Why? Because increasing the lithium dosage after delivery means already the volume is shrunken. Over and above that, if you increase the lithium, you will just exacerbate the lithium toxicity. And why not change to valproate? Well, the simple reason being valproate, number one, give rise increased risk of neural tube defects, as well as uh, there is no rationale for changing to valproate because lithium is already working in this case. Okay, so to summarize, in the first and second trimesters, we need to gradually increase the lithium dosages. In the third trimester, when the delivery is approaching, we need to decrease the lithium dosage. Immediately before delivery, you need to stop it because there will be a rapid volume shrinkage. Okay, thank you. Hope you have learned something from this lecture today.
So we are looking at a question from 2018 of AIMS exam, where it states that if carbamazepine is added to ongoing valproate therapy, what adverse effect is risked? A. Pancreatitis, B. Thrombocytopenia, C. is hepatotoxicity, and D. is hyperammonemia. Okay, so out of all of these question answers or options, the most appropriate would be hepatotoxicity. Okay, now this is a little bit controversial question, and the answer is also not that straightforward, but the only explanation that is there in Kaplan-Meier is hyperammonemia, which is rare, more common in combination with carbamazepine, associated with coarse flapping tremors and response to L-carnitine inhibition. This is the only thing that is written. But the only thing is that I want to tell is there is a difference with what we see in experience and what is limited to the textbooks. Okay, so the exam key will always say hepatotoxicity, but Kaplan-Meier says about only hyperammonemia, which is which is in Kaplan-Meier referred to as more common in combination with carbamazepine. Okay, however, from clinical perspective, hepatotoxicity becomes a greater risk, okay, rather than hyperammonemia. Although we should also keep in mind hyperammonemia is also a very commonly seen side effect, but not as common as hepatotoxicity. Okay, so whenever we go for monitoring for these patients, okay, so in monitoring of the patients, we order LFT, okay, we order LFT as well as serum ammonia. Okay, now we always order these two labs so as to monitor both of them at the same time. Okay, so the purpose of this question is to assess not only what is written in the textbooks but also to assess what you are seeing on a day-to-day basis. So first of all, this question is not only applicable in our psychiatry but also certain patients who are having little difficult to treat seizure medications. Okay, so the studies are also coming and the observations are also coming from that clinical perspective, from a neurologist perspective of treating a difficult to control epilepsy as well. Now, usually, whether in psychiatry or in epilepsy, we avoid this combination of valproate and carbamazepine because it is wrought with pharmacokinetic adverse interactions that results in adverse events as well as unpredictable dosages fluctuations. Because carbamazepine and valproate, both of them influences each other's pharmacokinetic metabolism. Okay, so the best scenario would be not to combine this at all. If, however, it is getting combined, then we should be thorough with the monitoring as well, not only through the labs, but also physically checking for signs of hepatotoxicity, okay, as well as serum ammonia. And LFT must be ordered as well. Okay, thank you. Hope you have learned something from this. 2023, mood stabilizer which causes hepatic failure, hyperammonemia, and pancreatitis. So it's a pretty straightforward question. A is lithium, B is valproate, C is carbamazepine, and D is topiramate. Okay. So we are talking about the triad of hepatic failure, hyperammonemia, and pancreatitis. Okay. So these are the exact FDA black box warning for a certain drug over here, and the answer is valproate. So these are the exact FDA black box warnings for valproate. Okay, so over here we can see. So this hyperammonemic encephalopathy, which is specifically underlying urea cycle disorder. Okay, this is often associated with underlying urea cycle disorder, hepatic failure and pancreatitis. Okay, this has to be remembered. This is pretty unique to valproate itself. Okay. There is one thing, although they're talking about this hepatotoxicity, hyperammonemic encephalopathy, specifically in those with uric acid problems, urea cycle disorders, not uric acid, urea cycle disorders, okay, not uric acid problems, okay. So baseline or serial laboratory monitoring does not necessarily predict severe hepatotoxic or pancreatitis, and close clinical observation appears superior to routine clinical monitoring in this regard. This is very important. So over here, we cannot be overly reliant just on the labs. We have to be also reliant on our own physical observations. Okay. So the clinical vigilance part becomes very important. And what should we be vigilant about? Like new lethargy, vomiting, abdominal pain, altered mental status. Okay. So these are some of the things that are more important than some lab values. And these are pretty unique to the valproate. None of the other drugs are showing this adverse effects. Okay. So always remember, whenever someone is talking about hepatic failure, hyperammonemia, or pancreatitis, okay, this combination, it has to be valproate. Okay. This triad is associated only with valproate. Nowhere else this triad will be found as a side effect of any other drug. Okay. So today we are starting off with the valproate PYQ series. So this is a question from 2025 of NEET PG. So a 40-year-old woman with bipolar disorder is planning for pregnancy. Which of the following drugs must be avoided due to possibility of neural tube defects? A. Valproate, B is oxcarbazepine, C is lamotrigine, and D is levetiracetam. So out of all of this, as it has been mentioned specifically as neural tube defect, so our answer would be valproate. Okay, so valproate of all of this is specifically producing neural tube effects. Okay, so we can see the quotations from Kaplan et al. As well as the graph. So valproate is having 20.3%. That is the highest risk, although it is dose related. Second is phenytoin, that is 10.7%. Third is carbamazepine, 8.2%. Fourth, the least is lamotrigine, which is 1%, which is why lamotrigine is preferred for reproductive age females who are uh, preferably having some planning for their
pregnancy as well. Okay, so one of the teaching is to avoid valproate in women of childbearing age wherever an alternative exists, and if unavoidable, treat it with high dose folate. Okay, now the reason is this. Okay, the reason is the risk with valproate is 10 to 20 times higher, which doesn't justify its usage in pregnant females. Okay, so in pregnant females, whenever we try to use, we use lamotrigine. If nothing else is possible, we give valproate. Otherwise, it will be very much prudent not to give valproate. Okay, this is what is written. So, lamotrigine has the lowest malformation rate of the anticonvulsants compared to the cited data, that is 1%, and is often preferred mood stabilizer alternative for pregnancy planning. Oxcarbazepine and levetiracetam are not associated with the same magnitude of neural tube defect risk as valproate, but they are nonetheless not as safe as lamotrigine as well. And another thing is that oxcarbazepine and levetiracetam are not effective as mood stabilizers. Okay, because in the question it is not about anti-seizure medication, it is about bipolar disorder maintenance. Okay, now why is this important? Because many of the times you might find some article or some seniors might be talking about, or some even references might talk about oxcarbazepine because it is derived from carbazepine, and you might think that carbazepine was an effective mood stabilizer, so oxcarbazepine might also become an effective mood stabilizer, but that is not the case. Oxcarbazepine has not been found to have any evidence in mood stabilizers, and levetiracetam never had any in the first place. So, oxcarbazepine and levetiracetam can never be our choice because it doesn't has any mood stabilizing property. Okay, thus the answer is valproate. Okay, and and lamotrigine as the mood stabilizers. Okay, but if we have to choose in pregnancy, then it becomes lamotrigine, which is a preferred agent because of the safety profile as compared to the valproate. Okay, so in total, if somebody with bipolar disorder is having pregnancy, we must look for agents that are safe for the baby as well as for the mother. Lamotrigine becomes a choice. If nothing else is working, then only we can give valproate. The other options are also lithium, but that is also having some other problems which we had discussed in the lithium series. Thank you. Hope you have learned something from this. We're looking at the question from 2017, which is a mood stabilizer with an anti-suicidal role. A. Carbamazepine, B. Lamotrigine, C. Lithium, D is valproate. So this is a pretty much straightforward question. The answer to this is lithium. Okay. So lithium acts as an anti-suicide shield. So lithium does more than stabilizing mood. It has a proven independent correlation with reduction in both serious suicide attempts and completed suicides. These things are very, very important. So among all the drugs in psychiatry, there are only two medications that have been implicated as anti-suicidal properties. Okay, so on the left side, you can see the drugs that are having the anti-suicidal property, which is lithium, which is a mood stabilizer, and clozapine, which is a neuroleptic or antipsychotic. Only these two psychotropics has consistently replicated well-documented anti-seizure properties. Okay, as we can see, these other medications like valproate, carbamazepine, lamotrigine, they are not having antiseizure properties. They are mood stabilizers. Okay, they are mood stabilizers, but they don't have independent anti-suicidal properties. Okay, so that's why this is a VIP nightclub where only two members are allowed and no one else is allowed. Okay, So let's see what is there in Kaplan setup. So one of the fascinating aspects of lithium's clinical usage is its proven correlation reduction in both serious suicidal attempts and in complicated suicide. So bipolar disorder is associated with high suicide rates, and thus this anti-suicidal effect is potentially very important. Okay. Yes. A mechanism for lithium anti-suicide action is not known, although it is practical and common sensical to note that clozapine is also proven to have anti-suicidal effects different from the other neuroleptic drugs. Okay? So you must remember this part. So this is often one of the areas which will be tested on because this anti-suicidal property is a very unique property among the psychotropic medications, which often is a favorite area of the examiners. So with this, we complete our section on lithium psychopharmacology. Hope you have learned something from this. Thank you. So here we have a question from NEET on lithium thiazide interaction mechanism. So a patient on lithium therapy developed hypertension. He was started on thiazides for hypertension. After a few days, he developed cold tremors and other symptoms suggestive of lithium toxicity. So explain the likely mechanism of this interaction. A. Thiazide inhibits the metabolism of lithium. B is thiazide acts as an add-on drug to lithium. C is thiazides increases the tubular resorption of lithium, and D is thiazides causes water loss, thereby increasing lithium levels. Okay. Now, the answer to this question is C. Thiazides increases the tubular resorption of lithium. Now, our kidney is sort of confused between the structures of sodium and lithium because they are chemically similar structures. So, as a result, in whatever ways the body is handling sodium, the exact mechanisms are applied to the lithium atom as well. Okay. Now, as we can see, whenever the kidney is trying to do the compensatory reabsorption, instead of taking sodium selectively, when a patient is on lithium, the kidney is going to reabsorb both sodium and lithium together, which is what leads to the lithium toxicity. And this is very important because whenever a person is having this hypertension problem, is having these issues and is prescribed by the physician either diuretics, it can lead to inadvertent lithium toxicity. This is also here in Kaplan setup, textbook of psychiatry. And not only that, if you look at the condition of lithium induced polyuria relatives, then also it is azide, which is helpful. See, paradoxically, hazard directives product sparing directly line and quite helpful in lithium induced polyuria relatives. So, as a physician and a psychiatrist should know about the interaction between anxiety and lithium. So a female patient was started on lithium therapy for bipolar disorder for 6 months. She kept a fast for few days due to religious reasons and presented with seizures, cold tremors, confusion, and weakness of limbs. So, which of the following investigations should be done to help diagnose her condition? A is serum electrolytes, B is serum lithium levels, C is ECG, and D is MRI. So, this is one of the scenarios that was given in NEET 2020. What should be your suggestion on a person like this who has stopped lithium fasting? Okay. So the answer should be when we are suspecting signs of lithium toxicity, okay, which are the seizures, cold tremors, confusion, and weakness of limbs. So the answer should be always check for serum lithium levels. Okay. Now, why is this happening? That is a very good question. Okay. So the answer lies in this case. The kidney cannot actually tell apart between which is sodium, which is lithium. Okay, because when someone is fasting or having dehydration, there is decreased intake with sodium, and the kidney panics and it now aggressively reabsorbs sodium into the proximal tubule to save it. Okay, because it needs sodium. Now, because lithium is handled almost identically to sodium, the kidney accidentally hoards and concentrates the lithium too, which precipitates the toxicity. So it was supposed to take in only sodium, but because our kidney is confused, it also takes in lithium out of the confusion. Okay, because sodium and lithium are identical, which leads to the toxicity in this case. Okay, so whenever a patient is on lithium, we would always warn them whenever they are undergoing some dehydration, say suppose diarrhea, vomiting, or in this case, not eating for a while, they should be very careful and skip with the lithium doses if they are having these kinds of toxicity effects, and they must return to us immediately so that we can also address, or if they are already having toxicity symptoms like in this case, they must immediately go to a general hospital to get adequate hydration. Okay, so this is what is also written, you can see over here. So toxicity here manifesting as seizures, post-tremors, confusion, and limb. Okay, so this picture is also consistently with severe, that is greater than 2, as we have discussed. Greater than 1.5 is often the threshold for producing toxicity in lithium, but in case it's very prominent, so most likely the serum lithium level might be 2 or greater than 2. Okay, so we will go with serum lithium estimation. In this case, it will be life threatening. So we will be able to save a life by measuring the serum lithium levels. Okay. And the other things, electrolytes and ECG are reasonable supporting investigations, of course. Okay. But if we have to choose one thing, we will go with serum lithium. Hope you have learned something from this. We will meet in the next section. Oh. So we'll look into the next section, which is a question from 2020 of AIMS on lithium teratogenesis in pregnancy. So lithium usage in pregnancy can lead to which of the following teratogenic effects? Uh, so option A is cardiac effects, B is facial effects, C is CNS effects, D is urogenital effects. Now, over here, the questioners are trying to make you confuse between the teratogenicity effects of various drugs like valproate or phenytoin. Okay, so the answer would be based on this. Okay, lithium. Okay, so lithium leads to Epstein anomaly. Okay, so it's a exclusively cardiac defect. Okay, so it's a cardiac defect. Let us look into the picture in little bit more detail. So this is what Epstein anomaly looks like on X-ray. It's a box heart, and this is what it's looking on the echo. So you can see the right ventricle has atrialized, okay, and so as to become large. So see, this is the This over here is the actual right atrium, and over here it is as if the ventricle has been invaded by the right atrium over here, so as to make the ventricle also like an atrium. Okay, so if you look at the anatomical picture, it is something like this. So normally it is up to this right atrium, but in this case right atrium is invading into the right ventricle and making part of the right ventricle like a right atrium. It is because of the displaced leaflet of the tricuspid valve, which is the anomaly we are calling as Epstein anomaly. Okay. Now, if you look into the other defects like valproate or phenytoin, mainly leads to facial defects. Valproate and carbamazepine leads to neurological defects, but not lithium. So you must remember. So this is what CTP talks about, that's Kaplan and Sedok. So lithium has been considered a classic teratogen. It's clearly teratogenic frog embryos and bird embryo models. However, heme of patients born to mothers treated with lithium through their pregnancy have revealed rather modest, okay, and somewhat specific teratogenicity, which is the Epstein anomaly of the heart, which occurs in lithium treated pregnancies at elevated rates compared to the control pregnancies, but still occurs on a in a only very small percentage of total pregnancies of lithium babies. That means the estimation of teratogenicity with lithium is much less as compared to with that of valproate or carbamazepine or phenytoin. Okay, so those are far more teratogenic agents than lithium. Lithium is teratogenic, but not as much like the other agents. Okay, we have already covered this. So yeah, so always remember the kind of teratology is a well-tested area in AIMS or NEET PG. So you must remember this areas of specific forms of teratogenities that we can see with various drugs. Okay, thank you. Hope you have learned something. Okay, so this is a question from 2020 AIMS. This is a pretty interesting question on the timing of blood sample collection of lithium. So a psychiatric patient was started on lithium for the management of bipolar disorder. To monitor the blood lithium levels, at what time interval should the blood sample be collected after administration of the lithium tablets? A, after 24 hours, B, after 12 hours, C, after 6 hours, and D, immediately after taking tablets. Now, why is this important? Because the lithium levels will fluctuate and we want to record the lowest lithium levels that are there. That is the trough levels of the lithium, which is usually seen after a particular gap. Now, what is that gap? That is what they're asking. So the answer is after a gap of 12 hours. Okay. So let's see over here. So the rule is simple. Evening dose, you take the pill at night. Roughly after 12 hours, you draw the morning sample in the next morning. So this is a thing. So the drug surges in the bloodstream right after the dose. Okay. So you can see in the D option, this is the highest point. This is the peak point. We don't want to record the peak point. Okay. So we want the trough point. It's the quite well. It is the lowest concentration of the drug in the system just next just before the next dose is taken. Okay, so this is the trough. So that's what's so in Kaplan's log, they're telling lithium is a drug with a very narrow therapeutic index and high potential for severe toxicity. So careful monitoring of the serum lithium is essential. Okay, so that's why the lithium levels are drawn at 12-hour trough level, that is roughly 12 hours after the last dose, typically in a morning sample after the evening dose. Okay, and not only that, in addition to this, you must remember it takes around 5 days to achieve the steady state. Okay, correct. Okay, to achieve steady state. So what does that mean? So that means suppose we start today, okay, which is day 0. You start lithium, okay, say suppose 600 mg, okay, of tablet lithium, okay. Now you will not measure after 12 hours, okay. You will measure on the 5th day, okay. So you will allow the days to pass, day 0 to 1, 2, 3, 4, 5. On the day 5, okay, maybe on the 4th day you have taken in the night. On that, in the early morning, sample is taken, okay. In the early morning, sample is taken so as to record the truth. So the entire thing is, when you start a lithium, you give a gap of 5 days, and after that, on the early morning, you take the sample on after a gap of 12 hours. Okay, so you must remember this. This is little bit different from the usual medications that we see. Okay, but this is how it is done. Hope you have learned something from this. We will see you in the next section. So we're looking at the next question, which is from 2020 AIMS. So a patient is started on lithium therapy, which of the following side effects should the patient be asked to watch out for to monitor for toxicity? Okay. So A is malaise and sore throat, B is vertigo and diarrhea, C is fever, D is breathlessness. Now, if you observe very carefully, uh, the examiners are trying to make you confused between the side effects or toxicity of clozapine and lithium. Okay, so out of these two, the answer is vertigo and diarrhea. Okay, so the answer is vertigo and diarrhea. So let's just look at this thing. So in lithium, we can see the early warning signs are GI upset, including vomiting and diarrhea, as well as neurological like unsteadiness and vertigo. Whereas in clozapine, it is an immunological threat, okay, which will manifest as malaise and sore throat because of the underlying side effect of agranulocytosis. Okay, so exam tip would be don't mix the side effects of clozapine with lithium. Okay, always remember. So clozapine leads to immunodeficient side effects because of agranulocytosis, and GI and neuro side effects are because of lithium. Okay. So you can clearly see. So Kaplan Serok talks about above level 1.5, the plasma will above this 1.5 plasma levels will show toxic effects that will manifest as abdominal pain, polyuria, vomiting, and diarrhea. Okay, so the GI side effects. Okay, this is what we see. And once again, malaise and sore throat. These two are the side effects of clozapine-induced agranulocytosis, not lithium. Okay. So from this, hope you remember that agranulocytosis is a side effect of clozapine, not lithium, and lithium has side effects of GI and neurological. Okay. Thank you. We will see in the next question. Okay, so moving on to the next question in the lithium psychopharma series. So this question is on lithium toxicity. A patient with a history of mania on lithium therapy is brought with complaints of vomiting and multiple episodes of diarrhea. On examination, forced tremors and an ataxic gait are noted. So what is the expected level of serum lithium in this patient? So as discussed in the previous question also, at 1.2 we are capping the serum levels, but at 1.5 milliequivalent per liter, we will see toxicity. So the answer will be 1.5 milliequivalent per liter. Okay, so this is the overall picture. So highest acceptability is at 1.2, and above 1.5 it's like really toxic threshold. Okay, we must never cross 1.5. If we are crossing beyond 1.5, then we should look into the matter and monitor the patient very thoroughly and round the clock. Okay. Okay. So this is what is also written in Kaplan and Sadok. Okay, very much. It was almost the same as the previous question. Now, based on this, we go to the next question. This one. Okay, this is a 2022 NEET question, by the way. So this also talks about toxicity, but what is the threshold for dialysis? So at what serum lithium levels would you consider dialysis in acute lithium toxicity? So obviously we can see all of these are in the toxicity levels. Now, at what point would you consider lithium toxicity? Now, answer to this is a little bit controversial because we have different sources. Like, for example, Goodman-Gilman talks about greater than 3, whereas Kaplan-Sadok talks about 4. So, to be on the safer side, we will go with B, which is 4 milligrams per liter. I'll give you the reason why. Because of this, okay? Now, dialysis is not magic. It actually requires a gradient, okay? So lithium only moves efficiently across the filter if the pressure or concentration, like concentration is also form of pressure, is high enough to physically push it into the dialysis. Okay. So this gradient has to be significant enough. And as per Kaplan and Sadok, this is occurring at a level beyond 2 to 3. Okay. So Goodman-Gilman is talking about at 3, although Kaplan-Seraf talks about 4. So let's see what does this Kaplan-Seraf talks about. So see, the dialysis is often done, but this value has been questioned often because the gradient of lithium at 2 to 3 in the blood is not strong enough to make for efficient dialysis. Okay, so based on this, we have marked the question as the answer as 4, not 3. Okay. So this is the explanation. So the exam's chosen answer is point 0.4 once again because we are following the Kaplan or Harrison's convention. The dialysis at 2 to 3 meter range is not often efficient because the concentration gradient across the dialysis membrane is too shallow. Okay, it's too shallow to clear the lithium quickly, reinforcing why the guidelines reserve dialysis only for higher levels of not at beyond 3 but beyond 4. Okay. And rest of the options is like greater than 2, it will at this level the patient will have significant seizure as well as cardiac toxicity but not a point of reaching requiring dialysis. Once again, the concentration gradient is not built or good enough to require a dialysis, or it's not possible to do a dialysis. Okay, the concentration gradient is weak. At 3 also the same, the Goodman-Gilman gives sufficient answer at this, but we are not going with this answer because the concentration gradient is not well built. Okay. So from this too, we come to a conclusion that although toxicity is 1.5, hemodialysis is only done at a certain concentration gradient, which is controversial once again. But we, in this case, we have gone with the standard Kaplan-Seraf guidelines, Kaplan-Seraf book, which talks about at levels beyond 4 milligrams per liter. Okay. Thank you. Hope you have learned from something. We will also look into further questions in the next sections. Thank you. Okay, so here we have the next question on lithium psychopharmacology, which is from INICET November 2022. The question is how much the therapeutic dose of lithium should be maintained in case of long-term bipolar disorder. So here the question is revolving around what should be the serum lithium levels in the maintenance phase in a BPAD patient. A is 0.6 to 0.8 milliequivalent per liter, B is 0.6 to 1.4 milliequivalent per liter, C is 0.6 to 3 milliequivalent per liter, D is 2 to 3 milliequivalents per liter. Okay, so this is a pretty straightforward questions. So we must always remember that lithium is having a very narrow therapeutic index. That means even the dose fluctuates little bit, it can move from therapeutic levels to toxic levels. So let's look at something which is known as the lithium meter. Okay, this is taken from Mali et al. 2017. Okay, so here is a number of guidelines which is not that important for you. Which is more important for you is this part. Okay, this part you should remember. So the maintenance phase is between zero point 0.6 to zero point 0.8. Okay, so our answer is zero point 0.6 to zero point 0.8. Okay, so this becomes our answer. So here we can see anything which is beyond 1.5 is clearly toxic. Okay, the highest acceptable therapeutic range is 1.2. Okay, so over here we can see everything other than option A has crossed 1.2. See, everything is more than 1.2. So wherever the option is one more than 1.2, it is going towards toxicity, and anything beyond 2 is definitely toxic. So these two things are never therapeutic. Okay. So this is what CTP tells, that the therapeutic plasma levels of lithium range from zero point 0.5 to zero point 0.8. This is for the maintenance dose, as we have seen in the lithium meter, and levels above 1.5 shows toxic levels. Okay. So once again, we just see. So see, depression is covered by a serum lithium levels of zero point 0.4 to zero point 0.8, and in the acute manic phase, it should be between zero point 0.6 to 1 millimoles. Okay. So once again, depression is zero point 0.4 to zero point 0.8, and mania is zero point 0.6 to 1. Okay. So this is one of the summarizing diagrams I'd like to show. So below zero point 0.6, it's ineffective where there is a high risk of relapse. So this is for prophylaxis. The ideal range is zero point 0.6 to zero point 0.8. In zero point 0.8 to 1.2 is for acute mania, which we usually keep during a small duration till the acute manic phase is over. And beyond this 1.5 as per CTP, or even according to the lithium meter, that is Mali et al., it is more than 1.2, which is the toxic threshold where we can see the side effects like vomiting, diarrhea, seizures, even cardiac abnormalities. Okay, so this is few of the numerical values that you must remember, because these are often there in the previous year questions. So as a shortcut, always remember, if someone is talking about lithium levels, it's never crossing 1 because it's always below 1 for all generalization purpose. Anything below 1 is can be considered normal, and anything above say zero point 0.5, which is zero point 0.6 over here, but for a rough guide, so anything between zero point 0.5 to 1 can be considered a normal. Okay. Out of this, if you have to further refine it, it is zero point 0.6 to zero point 0.8 for maintenance phase, and zero point 0.8 to 1, or sometimes people tell it as 1.2 as the acute manic phase. Okay. Okay. So with this, we complete the discussion of this question. Hope you have learned something. Thank you very much. We will see in the next session. So, welcome everyone. We'll be continuing with the lithium psychopharmacology sessions. So today we have a question from INICET May 2023, which says, which of the following is true about lithium? So option A is fine tremors are seen at therapeutic blood levels. Okay. lithium is not absorbed from the gut, C doesn't cause teratogenicity, and D is approved for abscesses. Now, which of the following is true? Now, the answer is that even at the therapeutic blood levels, we are seeing fine tremors. So, fine tremors are not actually associated with toxicology of the lithium. It's actually the coarse tremors, which is a part of lithium toxicity. Okay, so let's just look into it. So, see, this is how it is. So, fine or postural tremors, this is perfectly normal, not a sign of toxicity. Okay, so this is propranolol responsive. However, it is this coarse tremors which is of immediate, which needs immediate intervention because it's a clinical warning sign of intoxication. So, see, so if it's fine like this, just propranolol is our only response. But if it's coarse, then it is a problem. Okay, so the coarse form of tremors of lithium is the thing that we should be worried about. This is toxicity. Okay, so this is what is the textbook says. Textbook is Kaplan and Setup. So lithium induces in most patients a mild resting tremor, should be examined regularly by the psychiatrist in the office by observation. This is not a Parkinsonian tremor. Lithium may result in an action tremor at, so it is an action tremor. So whenever the patient will try to say pick up some object, when an intention or action is there, then only there will be tremors. Okay, that's also a mild resting tremor. So it's a resting tremor or a action tremor. Okay, and these are all at non-toxic therapeutic level. So resting tremors as well as action tremors. A stable lithium tremor is the absence of in the absence of toxicity may, however, be distressing and impairing to the individual. Yes. Nonetheless, although it's not a toxicity, it will be a source of distress for the patient, specifically for those people who are on a daily basis using their fine motor skills, like a musicians or perhaps a surgeon or an orthopedician. They will be facing a problem which is distressing for their work life. Okay. And for this fine tremor, we are giving propranolol, maybe say 30 mg in three divided doses. That is 10 mg in three times a day. Okay. So let's see the other options. So option B is wrong. Lithium is a quite small uh, agent. Actually, it's high, as a result of which it easily crosses the gut lumen and into the blood. Okay. So this statement that it is not absorbed from the GI system, that is completely wrong. Okay, C is wrong because C is telling that it is not causing teratogenicity, but we know that lithium is indeed a classical teratogen. It is producing this Epstein's cardiac anomaly. Okay, which is associated with elevated risk of displacing the tricuspid valve. Okay, so this becomes something like this. Okay, it will be something like this. This is Epstein anomaly. Sorry, this is actually sort of like this. Okay, it will be displaced somewhat over here. Okay, so as a result, there is actually uh, the chamber of the right ventricle is smaller in volume, as well as the blood is not getting emptied properly from the right atrium into the right ventricle. So it will be say like somewhat like this. Okay. So the blood won't be able to pass into here. So this is the anomaly with lithium that we are seeing. And the third was mood stabilizing properties. Okay, that lithium was supposed to have mood stabilizing properties, right? Approved for absence users, but no. Lithium doesn't have any role in absence users, not it is having any anticonvulsant property. Okay, so among the mood stabilizers, we can see over here that carbamazepine and valproate are the only two who are having both mood stabilizing as well as anticonvulsant properties. Over here, ethosuximide is the pure anticonvulsant which we are using, and lithium doesn't have any anticonvulsant property. It is only a pure mood stabilizer. Okay, so with that, we cover today's MCQ. Hope you have learned something from this. Thank you.